Good afternoon, everyone. It is my pleasure to present this webinar today. My name is Professor Marta Cohen. I am the Vice President for Learning at the Royal College of Pathologists, and I am also here in my role as Chair of the Postmortem and Forensic Microbiology Group of the European Society of Microbiology, ESCMID. And these webinars that are two. Today is the first one. The second is going to be on the 5th of March, same time on bacteria. Today is viral infections from the autopsy room to the laboratory diagnosis, and that has been jointly organized by the Royal College and by the study group ESGFOR of ESCMID. The webinar will run approximately 1 hour. We have two esteemed speakers, and each of them will present approximately 20 minutes. And at the end, there will be the questions and answers. So please, there is a Q&A at the bottom, and then you can write the questions there, and we'll read them aloud at the end. Also, this webinar will be recorded, and you can always access later. And you can also save credit for 1 CPD points for attending today's webinar. So the first speaker is Dr. Esther Yaut, and she is an autopsy pathologist at the University of Glasgow, with particular interest in sudden cardiac death, maternal death, and medical education. She is the chair of the Royal College of Pathologists Death Investigation Committee, chair of the UK Cardiac Pathology Network, and also reviews maternal death for Embrace UK. She is the Royal College of Pathologists Clinical Director for Digital Pathology Education, a role which encompasses oversight of the pathology portal, and she's external examiner at Queen Mary University of London and an examiner for the CHAT exam of the Royal College. So thank you, Esther, and we'll go to Dr. Raza, will be the next speaker. Thank you.
Thank you very much, Marta, for that kind introduction and for asking me to speak today. I'm a general autopsy pathologist doing adult autopsies. I don't have a particular expertise in viral infections, but as an adult autopsy pathologist, I come across viral causes of infections and causes of death at autopsy. And so I'm going to share some of that experience with you today. I'm relying on my co-speaker, Dr. Raza, for the technical details around virology, testing and interpretation. And I think this is going to be an excellent session. So just a warning, first of all, I'm going to show some images in this presentation that are taken at autopsy. And so if you feel upset at all, just look away from the screen for a few moments. So whenever we talk about infections, I think you need to talk about health and safety in the post-mortem room. So that's where I'm going to start. And just to say, the most common viral infections that we encounter at autopsy are the blood-borne viruses. So hepatitis B, hepatitis C, and HIV. Other things that I'm going to cover in this talk include other viral infections in the respiratory tract, in the heart, the GI system, the central nervous system, and I'm going to touch on some paediatric cases as well, kindly shared with me by our chair, Marta. So when we're talking about blood-borne virus infection, we will often see this in adults who are, for example, injecting drug users and therefore at high risk of blood-borne virus infection. But you have to take a broad, cautious approach when doing autopsies, because anybody could have a blood-borne virus infection that you don't necessarily know about. So with blood-borne viruses, the main risk is about inoculation or contamination of mucosal surfaces. So the most important thing that we need to do in the mortuary, first of all, is be safe with our sharps. We've got several knives that we're using for dissection in the autopsy room, and it's really important that you know where your knives are and that you're not covering them over and therefore risking cutting yourself or being careless with your knife. We would tend to use enhanced personal protective equipment. In general, it's a good idea to use 2 sets of gloves. Also to have a cut-resistant glove, which is worn on the non-dominant hand, because that's the one you're going to stab yourself with. We also use a face visor that covers off your mucosal surfaces, and it's also advised that you use a gown. When you're doing a risk assessment prior to the autopsy, it's important to try and get as much information as possible in order to be able to assess how great the risk is for you and therefore what protection you should be employing. And you can get lots of useful information from the GP records, from hospital records. You might have information in the police report or the coroner's information. You might have extra information from addiction services if they are a drug user that's attended addiction services, because they will often test for bloodborne viruses on a regular basis. You might get information from family or friends or witnesses to the death. You might even get some information from body clothing. So as the clothing is being removed by the mortuary staff, they may find objects within the clothing, for example, needles that might point towards injecting drug use and therefore a higher risk. And you might see some useful signs on external examination, for example, if they do have track marks, if they have groin sinuses, that might indicate that they are an injecting drug user. But I would say information is good, but it doesn't always tell the whole story. For example, you might have somebody who has had hepatitis C in the past, has been treated for hepatitis C and is no longer was then tested negative. But I would treat that with caution because they may have continued with risk-taking behaviour in the interim period, and it's not uncommon to be reinfected with hepatitis C. So I would just take a general cautious approach when it comes to bloodborne virus infection. So sticking with the bloodborne viruses to start with, this is hepatitis C. So here we have a cirrhotic liver, which you can see the undissected appearance on the top left, very shriveled up, shrunken, nodular liver. And this is very difficult to cut across. It feels very firm with the knife when you're cutting across it. And on the cut surface on the top right, you can see lots and lots of small nodules throughout the liver. So this is a micronodular cirrhosis. And in the image, the histology image at the bottom, there is a portal tract here with inflammation, usually lymphocytes, plasma cells, some neutrophils. And in this case, they're spilling out from beyond the limiting plate of the portal tract into the liver parenchyma. And this is just a typical histology appearance of hepatitis C. Now, hepatitis C doesn't tend to kill you directly, but we may see the consequences of liver cirrhosis that therefore cause death. So things like gastrointestinal hemorrhage, you may see hepatocellular carcinoma and other complications like that. HIV is one that we worry about at autopsy. With hepatitis C, we've always been concerned about it, but there's now a very successful treatment available for hepatitis C. With HIV, of course, there is very effective treatment available, but it's not curable. So it's still a concern at autopsy. However, if somebody has been treated for HIV and their viral load is undetectable, that's considered untransmissible, and therefore the risk to the autopsy pathologist is just the same as somebody that doesn't actually have HIV. So having that information about HIV viral load and when it was last tested can be really informative when you're risk assessing at autopsy. So there's obviously a risk about transmission of the virus if you did have an injury during the autopsy dissection. But in terms of the cause of death, HIV usually causes death by opportunistic infections or associated malignancies. And on the right here are two examples of opportunistic infections. This was actually from the same patient. And both of these are presenting in the brain with abscesses, multiple abscesses in the brain. And the histology showed toxoplasmosis at the top and cryptococcosis at the bottom. So a word about sampling before I move on to some of the moving away from bloodborne virus infection. So I would say it's important that you talk to your virology lab and know what they require in order to be able to do testing. But the basic thing that you'll need is a swab, and you'll probably want some sample medium to put that swab into and to send up to the lab. Having said that, some labs are different. I used to work in Wales where they just used dry swabs. So you would just take a swab and send that dry swab in a usually break off the end and send it in a universal container to the lab, and then they would do the testing. Where I'm based here in Glasgow, they prefer to have that swab washed out into the medium that's in the pot here, and then we send that up to the lab. So you need to talk to your laboratory. But most of the types of infection that we'll come across at autopsy, it's very simple just to take a swab. So I'm going to start talking about respiratory viruses and their infection and their causes of death. And you can get lots of useful information about what's going on, particularly in the UK, probably in your own countries as well. I know that our audience is international today. In the UK, the UKHSA has a dashboard which you can see fairly up-to-date information, and this is just a screenshot of the respiratory viruses over the last year, and you can see the peaks that we had of influenza in December last year, and now tailing off, and the same with RSV and COVID. So it's useful to know what's out there, and therefore what you might come across at autopsy, what you might need to think about when you're doing your dissection. So starting off with COVID-19, in the UK, there were apparently 25 million confirmed cases. That number is probably out of date because we stopped doing widespread free testing in 2022. So testing is now much more restricted to people in hospital. There were over 230,000 deaths in the UK. And I had a look back through our database in Glasgow over the last 5 years, and COVID represented about 1.2% of autopsies in the last 5 years. It really has tailed off in the last few years. In 2020, 2021, 2022, we had a large number of cases, and in the last few years, obviously far fewer. What the lungs look like in COVID is hugely variable. Particularly at the beginning of the pandemic, when people didn't have any exposure to the virus previously, no immunity, no vaccination, we were seeing people with very, very heavy lungs, heavy, firm, congested lungs, no pus to be expressed from the cut surface of the lungs. That's something that you'll see in bacterial infection, but in viral infection, you can't express pus because because there's no neutrophils. So one of the things that we did see, and this is not specific at all, one of the things we saw was that the lungs were very firm and had what's known as hepatization. So the lung surface looked like liver. And red hepatization and grey hepatization are changes that are described in lobar pneumonia, which is usually a bacterial cause. But we were also seeing it in COVID as well. And this is what this photograph here shows. The cut surface of the lungs with grey hepatization. The paler areas are very, very, very firm, really solid lungs, can't express fluid or anything from the surface, but were very, very firm and very heavy. And this is what the lungs look like microscopically. So a picture of a normal lung on the left, just to remind yourself, very thin alveolar walls, really good for gas exchange with tiny little capillaries running through them. And on the picture on the right of a case of COVID-19 is taken pretty much at the same sort of power. But you can see there's really obliteration of the alveolar structure. The alveolar walls themselves are very, very thick. They look quite blue because there's lots of cells in them. Those cells are lymphocytes. The alveolar lining cells, the pneumocytes, are really enlarged and they're falling off, being shed into the alveolar space. And there's lots of fibrin being produced. All the pink material is fibrin, and it's lining the alveolar walls and sitting within the alveolar space. And you can appreciate how that affects gas exchange in the lungs. But I would say viral infections don't have any specific features of a particular cause. I'm going to show you some other causes, other histology images for other viral causes of pneumonitis. But I want to convince you that there's nothing specific about these. So here we have a case of influenza A, which represented 0.2% of autopsies in Glasgow in the last 5 years. And again, we've got thickening of the alveolar walls, we've got lymphocytes infiltrating them, we've got fibrin being produced, and there are balls of fibrin as well as membranes of fibrin in the alveolar spaces here. But it shares a lot of similar features with COVID. And here we have a case of rhinovirus, which again shows similar features. This is a much higher power view here. But again, you've got thickening of the alveolar walls, you've got lymphocytes, you've got fibrin being produced, membranes of fibrin, balls of fibrin sitting in the alveolar space. And you can't actually tell these apart by looking at the histology. We really do rely on our virology testing. So you cannot look at a lung either with the naked eye or the microscopic appearances and say, this is COVID or this is influenza. You need to have the virology testing in order to be able to confirm which virus is the causative organism. And then this is an unusual virus, which we really don't see very often. I've probably seen 2 cases of a giant cell pneumonia, which is caused by measles. And in this sort of case, I think it's useful to know what's going on in your local community. Has there been a recent measles outbreak? Is there anything in the history of the deceased that might point towards this being measles? But if you see giant cells, a giant cell pneumonia, think about measles, and it's always worth testing. So I'm going to move on to the heart now, and myocarditis is the most common viral infection in the heart viral infection in the heart causes myocarditis, and the most common cause of myocarditis are viral infections. There are other causes as well. This list is taken from an upcoming 3rd edition of Cardiac Pathology, which I would recommend you buy when it's published later on this year. And you can see there are a number of different viruses that can cause myocarditis, and lots of other rarer causes. The difficulty with myocarditis is it's something that you pick up on histology rather than having any particular clues with the naked eye when you're doing your autopsy dissection. So this is a microscopic image of myocarditis. And you can see that there are cardiac myocytes here, the large pink cells are the myocytes, but there's also a florid inflammatory component between the myocytes and then causing damage to the myocytes as well. So there are myocytes here that are being attacked, they're being gobbled up by the inflammatory cells. So you have inflammation, myocyte damage, and this is myocarditis. Now, in my local practice here in Glasgow, looking over the last 5 years, myocarditis accounted for about 0.1% of autopsies. So it's really not very common. And as I said, there aren't really very many clues that you can see from the naked eye to make a diagnosis of myocarditis. It's usually something that you pick up when you look at the histology. It may be that there are some clues in the clinical background about how the person has presented, but you may have somebody that's just died a sudden death and an autopsy looks negative. The heart may look completely negative. It may be mottled, but the macroscopic changes can be really subtle. And then you get the histology through and you see this rampant inflammation. By this time, of course, it's too late to take a swab. So we're in a pickle then of trying to identify the type of virus that might have caused this. Now, it's possible to send samples from the histology lab to the virology lab to do PCR to try to identify a virus. I have never been successful in doing this, unfortunately. I've tried several times, but we've never been able to identify the virus. And I think this is one of the places where paediatric pathologists really excel because of the sampling protocols that are different in paediatric pathology cases. They tend to take samples of fresh tissue from the heart as a routine. And so therefore, when they come across the myocarditis, they have that sample available to do the testing. And they are much more successful at identifying viral causes of myocarditis. So moving on to the central nervous system, the 2 big infections are going to be meningitis and encephalitis. And I'm showing you here a picture of meningitis, but I'm cheating because this is not a viral infection. Unfortunately, this is a bacterial meningitis. You can see that the brain has this exudate over the surface, which is bright green, luminous green. And this is almost certainly, this is a bacterial meningitis. Viral meningitis is far more subtle, and it may be that there are very few clues when you're looking at the brain macroscopically. You may see that the meninges are more clouded, perhaps not quite as translucent as you would expect normally. And if that's the case, I will often take a swab, both a Bacti swab and a virology swab, and cross my fingers and hope that I might be able to identify something. But it may be that you take a histology sample of the brain and identify a viral meningitis on the histology rather than necessarily with the naked eye. Similarly, with encephalitis, the brain may be swollen, so it may be sort of non-specifically edematous, but you wouldn't be able to see areas of encephalitis with the naked eye, but it might be something that you pick up on histology. And these are just a couple of examples of encephalitis on the histology. So on the left-hand side, you can see there's a lymphocytic infiltrate throughout the brain, particularly predominantly around the blood vessels. This is actually an autoimmune cause of encephalitis, not viral encephalitis, unfortunately. But the example on the right is an example of rabies in the brain, and this is taken from the Neuropathology Atlas by Washington University, which is available online, and they have some beautiful images that you can have a look at there. So this is beautiful negri bodies of rabies encephalitis, thankfully rare. So moving on now to GI infections, this is an uncommon cause of death. Looking back through our data, it was 0.05% of autopsies in Glasgow over the last 5 years, and that includes bacterial causes and protozoal infections as well. Viral infections, I think we potentially underestimate as a cause or contributory factor to death, but it can be a significant cause of death, particularly norovirus. Also other viruses, rotavirus seen in children, adenoviruses and astrovirus as well. The particularly vulnerable patients are children and the elderly and those with immunocompromise. And norovirus is estimated to cause 900 deaths per year in the US and between 50 and 80 deaths per year in the UK. And essentially, GI infections will cause dehydration, will cause electrolyte imbalances, and you can get associated cardiac arrhythmic death. Now, if you've got a history of diarrhea and vomiting in a patient, you can take a stool sample, and I've done that multiple times, and our lab will test for the common causes of gastroenteritis, which I've listed some of them here. Unfortunately, they don't test for viral causes. So there have been occasions where the stool sample has been negative, and I've had to gently say this may be a viral gastroenteritis that we haven't been able to confirm. So I'm now just going to talk quickly about paediatric viral infections, and these are this information is kindly shared from Marta, who's a paediatric pathologist, and so I'll deflect any paediatric questions to Marta. But still, viral infections do cause stillbirths, and it's a big problem. Just as a reminder, in the photograph there, you can have ascending genital tract infection coming up through the vagina, through the cervix, and then across the placenta, across the amniotic fluid into the baby. Or you can have hematogenous spread via the placenta and the umbilical cord to the baby. So these are some of the infectious causes of stillbirth. Bacterial causes are probably more common than viral infections, but there are lots of viral infections that can cause stillbirth. And I'll just show you an example of some of these. So what you see with the histology, when we look at the placenta, you'll see chronic velitis. And this is defined as lymphocytes and macrophages in the placental villi, which you can see on the photograph on the right there. And most velitis is idiopathic, so velitis of uncertain or unknown etiology, and around 5% of them are infectious causes. And this is where the TORCH acronym comes in, and you'll remember what TORCH stands for. So viruses feature very heavily in TORCH infections. Some of the other category, the O of torch, those other viruses are listed there. And just to show another couple of images of different patterns of villitis, you can get a diffuse histiocytic type, or you can get areas where there's fibrosis and calcification of the villi. Syphilis is part of that O category of the torch, and it causes a necrotizing phlebitis, and you can see spirochetes on the silver stain, which is the stain on the bottom right. CMV, one of the most common viral causes of congenital infections in developed countries. And according to the CDC, about 1 in every 200 infants is born with congenital CMV infection. And 1 in 5 of those will have long-term health problems. Now, some of those will be diagnosed shortly after birth. You can use PCR to detect viral DNA. Those that develop problems later in life, you can even go back to the dried blood spot, the Guthrie card, and test for CMV on that. And the photographs on the right illustrate some of the complications of congenital CMV. It's a multi-organ problem. It involves the reticular endothelial system, the central nervous system, the eyes, the ears. You can see hydrops, intrauterine growth retardation, jaundice, hepatosplenomegaly, petechiae that we saw on those photographs on the previous slide. Deaths tend to occur due to liver dysfunction, bleeding, DIC, or they can get secondary bacterial infections. And CMV is a leading cause of brain damage and sensorial hearing loss. The histology is always very beautiful if you can identify the very typical owl's eye intranuclear inclusions. And you can also get granular intercytoplasmic inclusions as well on histology. And now I'm just going to talk about something that we probably don't really think about very much here in the UK, but it's a big problem worldwide. So dengue fever, half the population of the world is at risk of dengue. And in 2024, there was a big peak of 14.6 million cases reported by the WHO and 12,000 deaths worldwide. And it's possible to have maternal transmission of dengue virus. It's also spreading to new areas, which is why we all need to be aware of this and other unusual infections, because worldwide travel means that that viruses are spreading to other countries that are not really necessarily used to seeing them. And in 2024, there were 308 cases reported to the WHO from France, Italy, and Spain. So it's closer than you think. This is the map of infections just for the first 3 months of 2024, and you can see the darker colours, the darker blue, being those countries with highest rates of infections. And there was this lovely study in the International Journal of Infection that looked at 24 patients with dengue fever during pregnancy, and they looked at the placenta and ovular remnants, and they could find dengue virus positivity in the immunohistochemistry in 92% of cases. And they saw in the placenta signs of hypoxia, choriodeciduitis, and intervillositis. And they could detect the viral antigens. And you can see that in the photographs on the bottom there, the positive immunohistochemistry in the decidua, the villostroma, and in the trophoblast. And the hemodynamic changes experienced by the mother can cause problems with the baby. So I'm going to stop there and hand over to our next speaker.
Thank you, Esther. Fantastic. Very nice presentation, roller coaster running. So thank you, and it's my pleasure to introduce Dr. Mohamed Raza, who is a qualified doctor graduating as an MBBS in 1996. He later obtained his MRCP diploma from the Royal College of Physicians of Edinburgh and worked as a trainee in various medical specialties. He later trained at the Royal Free Hospital in London in medical virology and Sidelight joined Sheffield, teaching hospitals. His special interests include influenza, cytomegalovirus, hepatitis B, infections in immunocompromised, and the use of point-of-care testing in microbiology. Thank you, and I also welcome my co-organizer and friend, Dr. Noha El-Saka, Vice President for Communication for the Royal College of Pathology, and also a microbiologist. So thank you. And after everything, we have a lot of questions already, 12 questions. So I leave it to you, Rasa.
Right. Thank you very much. Thanks for the introduction, and thank you for asking me to come and deliver. And I'll try my best to share my screen without any problems. And if I do have problems, I know. Just give me 1 second. Right. Okay. So you've kindly done my introduction, and I'll just crack on straight to my first slide. But before I do that, I'll just briefly talk about the objectives and the talk outline. So basically, this is aimed at the histopathology audience. So if my infection colleagues find it a bit too much of basics, apologies in advance. I'm going to talk about and give you an overview of available diagnostic tests in virology, and then some detailed discussion on the molecular diagnostic, including some variations which are required for tissue samples, and a bit about sample requirements, and then discussion on the significance of results. Now, viruses, if you think about it, if you ask yourself the question, what are viruses? Viruses are basically a piece of genome material which serves the purpose of creating progeny viruses and extending the life of the lineage. They are a small piece of genetic information inside of a protective shell, and some viruses also have an envelope. And these are basically non-living acellular infectious agents. And what they basically do is hijack the host cells to replicate, acting as obligate intracellular parasites that lack cellular machinery and cannot reproduce individually. Now, this diagram shows you, I think it's a COVID virus, but I can't remember. And it tells you the structure of what is a good example of what viruses look like. And the important point to note here is that there are surface projections called antigens, which are useful for cell entry, etc. And within them, there are other antigenic components, which are important for structural integrity. And it is important to know about those because these are the ones which we can use for diagnosing the infections. And viruses on the scale of the size are one of the smallest pathogens, if you ignore the CJD side of things. And the natural course of the vast majority of infection is that they are self-limiting, but there will be some variation in some of the infections where you have a chronic infections, or there are some infections which can cause cancers. And the diagnosis is usually done by modern diagnostic tests. The vast majority of infections go undiagnosed and are clinically diagnosed. Now, how do you make the diagnosis? You submit samples from the areas where you think the infection is affecting. The usual sample types we receive in normal diagnostic outside the postmortem are blood and serum, nasopharyngeal swabs, saliva, stool samples, CSF, tissue biopsies, and swabs from the affected compartment. It's important to note the timelines because these are used for sample choice and also the choice of the tests. And this, again, is a good example as COVID, which has given a global attention to these details and also help in understanding the various phases. And what you can see here, the chances of discovering a pathogen in the very early stages are low, and it's only just before the onset of symptoms, generally speaking, that you detect the virus itself, whether it's in the form of an antigen test or whether it's an RNA or a DNA test, after which the immune system kicks in, tries to get rid of the virus, succeeds, and as part of that, you produce IgM antibodies and IgG antibodies, which again, you can detect and make a diagnosis. So if you think about viral diagnostics, you've got a pathogen. Yes, it's very small, but the most logical thing is try to visualize it. And that's what happened. I think it was early 20th century when electron microscopy kicked in and people started to look at various samples and they started to find various viruses. But without that, obviously, it's difficult. But then you could also indirectly try to see the virus, which is in the form of viral culture, where you look for cytopathic effects. And you also do routine histopathology with the likes of immune histochemistry. These methods are laborious. A lot of expertise is required. There's a lot of setup, which is and training, which is required. And not all viruses are visualized under the electron microscope. You can alternatively look for immune responses, especially for acute infections, look for IgM. But then remember, there are biological delays in production of antibodies. For example, hepatitis C may not give you an antibody response for up to a year or more than a year. And sometimes when you do detect these antibodies, they lack specificity, which means that you can get false positive. So generally speaking, what we say is try to detect the virus directly, and you can do that in addition to what I've described above as form of antigen detection and detection of genetic material. Now, over the years and over the last few decades, what we've seen is a big time evolution of diagnostics. So the clinically useful turnaround times were initially lacking. The viral culture, typically, for example, CMV took 2 weeks to report. The costs have come down because of the volumes of the work, and the automation is now in place, which allows us to justify the use of these modern instruments. As I said earlier, electron microscopy and viral culture have got limited utility and not viable simply because they're too expensive to run, and there are other better methods. The detection of viral genomic material to diagnose acute infection is quite useful because there's quite a narrow diagnostic window period to diagnose quite a few of these infections. CMV, if you miss the acute phase and the virus is no longer there, then you've got alternative methods of serology. But then if you are in the acute phase and the antibodies are not there, then you will choose this instead. And of course, you can use PCR testing for managing chronic infection. Screening tests remain mainly as serological tests. Now, in the context of postmortem, so what are the additional aspects you have to consider? The good thing from a diagnostic point of view is that there's a broad range of body sites which you can sample, and you can make a good overall picture of what you're looking at and what sites are affected. And then you can collect samples which you don't otherwise based on the findings at autopsy. One of the things which we hate as virologists and infection specialists is when we get samples in preservatives, because that destroys the yield of the DNA or RNA, which you otherwise expect. So what we say is that use a sterile container and do not add any preservative. And we will gladly process dry swabs or those in the viral transport medium, although those were mainly for culturing the virus and not PCR testing. So the forms of direct viral detection, which is important in the context of autopsy, because you're not looking for serological responses, you're looking for the virus directly, which happens in the form of immunohistochemistry, done mainly by histopathologists, but we also do detection of genomic material. And on top of that, you can do some serological tests for antigen detection. The molecular detection, however, is the standard test, which is widely used nowadays. And it has got different the words which you'll come across: the NAT testing, DNA testing, RNA testing, PCR, TMA, the strand displacement assay, isothermal amplification, and ASPA. These are all examples of molecular tests. And remember, what we are trying to detect is a molecule of DNA or RNA. So that's what this has become as a standard. So let's go into a bit more detail of what these nucleic acid detection. Now, this is just an attempt to demonstrate what PCRs are, because some of these steps may help explain what the results are generated from the laboratory. So PCR is a common laboratory modality where you try to amplify the number of DNA or RNA copies if it exists in a sample. So what you do is, in a PCR tube, you add the sample where you are trying to detect the DNA or RNA. You add a copy of the target material which you want to detect. So if you want to detect influenza, you put part of the influenza genome into that sample mix. You put some raw material in the form of nucleotides, because after all, you're trying to copy the the DNA. So you need the bases and other sugars and everything else. And an important aspect is the polymerase enzyme, which is the enzyme which amplifies and builds the copy of the DNA in question. And then you put that in a thermocycler, and there are various commercial names for it, but basically what the thermocycler does is it changes the temperature of the sample of the tube which I put in the thermocycler. And what do we mean by a cycle? Just to give you a bit more detail, the PCR it goes through different stages. The first one is to displace or separate the strands. It's a double-stranded molecule. And by raising the temperature to 95 degrees, this is what you do. In the second step, you try to bind the primer, which we've added as the DNA which you want to amplify, and the temperature has to be brought down to 55. Then the Taq polymerase comes in and tries to extend the molecule, which is done at 72 degrees. So you can see the series of temperature changes from 95, 55, 72, and they are done for various different durations, which is exactly what the design of the PCR is. At the time you're building up your new PCR, you have to see what temperature and duration you need for each PCR. And if each cycle takes about 6 minutes, 15 seconds, then if you're running 45 cycles, it's about under five hours of time taken for a PCR. And one of the important points here is the enzyme, which is inhibited by a number of items present in the sample, especially in the postmortem samples, which you want to get rid of. And this enzyme is the DNA polymerase, which also helps in the fluorescence process, which I'll describe in a minute. So there is no point in amplifying this product if you can't see it. So on its own, the PCR really doesn't give you anything. At the end of the 4.5 hours, you just get millions and billions of copies, but you can't visualize it. But the modification of this process has been done as real-time PCR, where you, in addition to the primers, you add, it's like a primer, which also has got a fluorescence dye. And as you're extending the DNA, what happens is the fluorescence dye is released, which you can then visualize in the form of a software. And what you're seeing here is the positive samples, as they are being amplified. You can see the fluorescence starting to rise, and there is an exponential phase where the PCR amplification starts to build up. Then there's a linear phase where the activity of amplification really goes high. And then as you deplete the raw materials, the nucleotides, the enzymes, it forms a plateau which represents the maximal activity. Now, if you detect the fluorescence early, that means that there's abundant material which is present. And there's a way of quantifying these. And what you do is you run known concentration of the virus, and then you see what the CT values you get. You build a standard curve and try to extrapolate what the concentration of an unknown virus is within that. So if you get a CT of 20, you'll know it's around 10, between 10 to the 3 and 10 to the 4. And the software will do the calculation automatically for you. So the specific requirement in postmortem is due to the deterioration of the sample and that the challenge it poses in obtaining an accurate diagnosis, the autolysis and putrefaction, which is decomposition by microorganism, begin immediately after death, causing rapid changes to tissues and fluids. Now, the question, and this is a challenge we came across when we were running out of our supplies for PCRs. Why can't we just take a tissue sample? Why can't we just add a swab and just put it directly through the PCR material? There's a step before that, which is called the extraction. And what the extraction does is it removes the inhibitors of the enzyme, which I described earlier on. It increases the concentration of the genetic material, and it lyses the cells. The DNA and RNA is present within the cell. So unless you actually lyse it, you're not going to be able to have a good yield. And it gets rid of all the nucleases, which prevents degradation. And direct PCR doesn't achieve any of that. And if you put that through the PCR, it will still give you the results. but the specificity or the sensitivity may be compromised. But note in forensics, for example, where the PCRs are used, you would like to have as much sensitivity as possible. But in the world of diagnostics, we always have an extraction step, which is just demonstrated by this set of workflows where you collect the sample, you do extract beforehand, and then you put it through the PCR setup. Now, for you to build up a proper PCR, you have to do a lot of validation and making sure that the tissue and various other sample types you receive, for example, in the context of autopsy, they give you enough yield, whatever that setup you manage to do. And there's plenty in the literature to say, look, these all work. And the number of samples we've received the last, I think, 2014 onwards, we started to receive all these samples, and you can see there's a wide variety of samples from almost all body compartments, which we have received over the years, from biopsies to swabs, from to BALs, urine, and all sorts. Now, what I'll go through now is quickly some cases. So this is a 1-month-old child who was found lifeless in a cot. She was noticed to have mild coryza before death and fever for the past few days. She was swaddled in a blanket with another blanket was over her face. And as part of the certain infant death, an autopsy was done with lung tissue and brain tissue and ear swab. There were no pathogen detected, but tracheal and nose swab had rhinovirus. So you could say just the child had a common cold, and it was not related to the certain infant death. On the other hand, another case, unwell for 6 days, was noticed to have shallow breathing at 5 a.m., lips were blue, looked pale and cold to touch. And she had an initial illness which had temperature spikes and cough, and family also had a similar illness. The nose swab had influenza A, rhinovirus, enterovirus, or paninfluenza, all 4 viruses detected. Tracheal swab also had flu and rhino, but brain swab, there was no pathogen detected, and lung tissue was also not there. Maybe there's a combination of 4 different viruses which created havoc in the immune system. There was a cytokine storm, or maybe the body was simply not able to handle this. But importantly, the lung tissue did not have any pathogen. It was restricted to the upper tract. So is this etiologically linked? Difficult to say. We'll speak to our histopathology colleague to see if there are any changes within histopathology, but we've heard as they talk about that, it's not always the case. So 2-month-old male, mom woken up by twin crying. That's when she noticed other twin to be unresponsive, pronounced to be life extinct. The tracheal swab, the right mid-ear swab, the left mid-ear swab, nose swab, brain swab, feces, all samples had a rhinovirus positivity. And the lung tissue did not have it. So bronchopneumonia, etc., no changes found. And the last case, the 3-year-old male had routine immunizations and flu spray, and 3 days later developed fever, and 3 further days later had diarrhea and vomiting. The feces and the swab of the brain had rhinovirus. The tracheal nose swab had influenza, enterovirus, and rhinovirus, but the lung tissue did not have any virus. So again, multiple sites, but nothing in the lungs. Over the years since 2014, you can see the number of viruses alphabetically sorted, which we have found to be positive. And the highest is rhinovirus. Then you've got enterovirus, and you've got some of the other ones, SARS, for example, respiratory viruses, and some of the less common HHV6 and HHV7. So what does that mean? Do we think that these were the causes of death? So the pointers towards etiological link are that if the virus is present at multiple sites, then it becomes more important. For example, adenovirus, disseminated herpes simplex, especially in neonates. Detection in compartment not known to harbor the infection. For example, you don't expect CMV, HHV6 and 7 in the CSF or brain because they're not neurotropic. So any presence is abnormal. Now, whether it's etiological link, that's hard to define. Herpes simplex is not present in the liver. So if you find it, then it's likely to be important. Very high viral loads and strong signals are usually more important than the low ones. And it's difficult. It actually helps identify for example, in acute infections, you've got very high viral loads, but if it's a reactivation, you relatively get low viral loads, especially when it's likely to be not relevant. And the pathogen which you're detecting at autopsy at the site of detection Is it normal to be present there? And what other findings did you have histopathologically? So that's the sort of an attempt to build up a whole picture, and then you try to find out whether it's important or not. Viruses deemed to be unusual, for example, H8V7, EBV. Is that because we haven't historically tested for those, or is that because they are important and these are just true cases and etiologically linked? Does the presence of virus fit in with clinical picture? So yes, we've seen kids, the cases I've described, they had common cold and we had rhinovirus. And yes, it fits in, but doesn't help in defining the etiological link. Can the virus be dismissed as bystander? Reactivations are common, and we see that all the time. Any insult to the body, immune system, you'll get reactivation if you got a latent infection. Presence of typical microscopic changes will help us understand and create a link. And then some occasions you have a viral load, which helps in differentiating where do you have a high enough viral load and you can just dismiss it just on the grounds that it doesn't make sense, because high viral loads are usually quite relevant, but then not all viruses can be quantified, although the CT values can give you some indications. And what about viruses which act as triggers? Should they be classed as the main cause of death? For example, the HLA syndrome, the cytokine storms we see, which are contributing or causing the death, but virus is just a trigger. And then there are deaths due to complications like myocarditis, where you may not find the virus, or you may find the virus, as we've seen in Esther's talk. And I'll just ignore that. So these are the couple of studies, and I'll just skip through these because we only got 10 minutes. So various groups have tried to establish links, and basically nobody has found a solid way of establishing a causal link. So in summary, the postmortem diagnosis poses different challenges, but offers breadth of samples and ability to correlate with histopathological findings. And the mere presence of DNA or RNA may not equate to an etiological link, and the overall picture needs to be considered. Maybe the metagenomics, when it comes in, will help us establish. So my histopathology colleagues, we are quite reliant on you guys to tell us the finding we've got in virology, whether it's significant or not. Thank you very much.
Thank you, Rasa. Fantastic, very, very helpful. And Esther, yes. So thank you both. And we have a lot of questions. So I will try to merge them. Arjun, and as I said, this is, I think, for you, Esther. The changes that you saw in the lungs, could it be due to secondary bacterial infection? And then what is the significance of finding viruses, especially in the respiratory, in the autopsy? We treat patients or might not for this. Okay, so if you can.
Yeah, I think the question about the macroscopic changes in the lungs, that grey hepatization that we saw in that particular case of COVID, it wasn't seen in every case, but that particular case, it could certainly be due to a bacterial infection, because like I said, lobar pneumonia presents that way. But in this case, it wasn't. It was just a viral pneumonitis. There wasn't any evidence of bacterial infection in that case. And in terms of the significance of finding viruses in the respiratory tract, I think actually Mohammed has covered a lot of this as well. It's really important that you put together what you're seeing at autopsy, both the macro, the micro, and the virology results all together in the context of how the person's presented. Interpret the virology findings in the context of what you're seeing in the tissue reaction in order to be able to determine their significance. I think when you get a swab from the upper respiratory tract that's positive for respiratory viruses, but you're not seeing changes in the lungs themselves, then that may be either a coincidental finding.
No, we can hear Esther.
There is a question from Veronique to Esther as well. Are these immunosuppressive?
Oh, I think Marta's having problems. She was going to ask, are there immunohistochemistry stains to identify different viruses? And yes, there are. If you're lucky enough to have a lab that does immunohistochemistry for various viruses. And I think in the paediatric setting, it's done far much more than we do in the adult setting. So it's really, really valuable to be able to identify that. But then you still have to also think about what is that causing within the lung? What's the tissue reaction? And therefore, then does it fit with how the person's presented? And therefore, is it the cause of death?
Yes. I think a question, this is for Rasa. If the sample from the myocardium can be frozen for viral studies.
Yeah, I think we do, as I said, the ideal sample is in cell line, but if you've got a frozen section, if you've got a frozen tissue, we can certainly process that. I mean, we do this to quite a lot of other samples. We can also process fixed tissues. We sometimes have processed material from the slides and the curls. So we do have those options. So if you've got a sample from ages ago, we can still process it. The yield may be lower.
Yes, absolutely. So another question for you, Rasa, from Sandra. A biopsy for virology is more versatile than a swab.
I mean, it's if you've got what we believe is that if you've got a tissue presence of a pathogen, that's more relevant and more significant in establishing an etiological link. The presence on the surface of an organ may not be as relevant. But again, that goes back to trying to link it with the histology. But I would say tissue is much better than a swab.
Okay, I think, let me see a question here for Esther. How do we differentiate acute myocardial infarction from myocarditis histologically?
So the key diagnostic features in myocarditis are an inflammatory infiltrate and damage to the cardiac myocytes. So those two are really important. Usually the inflammatory infiltrate is lymphocytes, and that's one thing that can help you distinguish myocarditis from acute infarction, because in acute infarction, the typical inflammatory cell will be neutrophils. You also see other features of infarction, for example, loss of the cardiac myocyte nuclei, hypereosinophilia, contraction band necrosis. So there are features that are quite different to distinguish both of those.
Yes. So another for Rasa, from Samuel, role of mRNA diagnostic to differentiate bystander versus pathogenicity of detected viruses. I think you have touched this, but
yeah, it's very difficult to do that in a very solid way. But as I said, it's the viral load usually tells you, because at the end of the day, it doesn't matter if it's a reactivated virus or if it's a exogenous primary infection. But I would say the only modality we've got is the viral load, and we make our own on judgment on that. But detecting bystander, it's very difficult.
Yeah, I agree. Viral load to me is very helpful as a pathologist. A question, I think for you as well, Rasa. How long can viral DNA persist after death to be detected?
Can't put a number to it. If it's been stored properly at the right temperature, I would expect that to last more for DNA than RNA. RNA does get degraded much more quickly than DNA. DNA more stable. So I would say attempt and look for a positive result. The negative result will not exclude it.
Okay, very good. Another for you from Raluca. Can I ask what is your standard protocol for disposing of postmortem virology tissue samples? So I think it's, for example, if we send a piece of lung to you, how do you dispose the virology tissue samples? Do they get disposed as per local SOPs, or do they go back to paraffin to become part of the medical record?
I think that process happens before we get the sample. And Martha, you probably can answer it better than I do, but I don't think we get enough sample for us to store. No. They're very, very small chunks, and we sometimes struggle to extract the sample. So I would say we dispose of them in the normal, usual way, and there's not much for us to store. It all happens in histopathology.
Can I add a perspective on that? I mean, I guess the question is probably coming from the thoughts about human tissue,
Yes,
use of human tissue taken at postmortem. I always consider, when I send samples to a laboratory like to virology or microbiology, I always consider that that's a sample that will be used up in testing and disposed of by the laboratory, that there isn't any residual tissue that's left over. So for the purposes of the Human Tissue Act, covering England and Wales, there's a different Human Tissue Act in Scotland, then you're not retaining tissue there. It's being used up in the process of testing. So it doesn't require consent from the family to retain anything more. It's used up and disposed of in the testing.
Yeah, agree. But I always send a swab or just a small amount. Yes, I think this question is for you, from Alan, Esther. Can cardiomyopathy present as myocarditis? Your experience?
My experience is that myocarditis and the various different types of cardiomyopathy, because there are lots of different patterns, usually have kind of separate and distinct histological appearances. His inflammation was historically described as one of the three key components, for example, of arrhythmogenic right ventricular cardiomyopathy. But actually what we see is fibrofatty replacement of the myocardium, and we don't see inflammation very much at all. So I think really that they have distinct histological patterns.
Yeah. If I may add here, because I had a case many years ago in which it was a dilated cardiomyopathy, and actually we did a virology PCR and viral load, and the child had a past parvovirus infection that was not with myocarditis, but then developed into a dilated cardiomyopathy. So actually, when I have a dilated cardiomyopathy, I always do virology, because 35% can be a past viral infection, which is, I learned with that case.
Yeah, that's a classic example, a dilated cardiomyopathy. Yeah. So past myocarditis is a very common cause of dilated cardiomyopathy. I mean, Absolutely. Many causes are not known, but always worth bearing in mind in dilated cardiomyopathy.
Yes. So there is a question here, as we see who is best to answer. A positive test for one virus or another is not always linked to the cause of death. During the COVID-19 pandemic, all patients were systematically tested upon admission. In one extreme case, a polytrauma patient who tested positive was classified as a COVID patient. However, his death was only linked to the massive blood loss and the polytrauma.
Yeah, this is that question that we've faced a lot and discussed in the media as well publicly through the COVID pandemic is, have people died of COVID, or have they died with COVID, or is it just completely coincidental? And that's something that pathologists always have to bear in mind. So you just have to take into account the circumstances of the case, the pathology that you're seeing, and the virology or other testing. But just because you've got one positive test doesn't mean that is significant. You have to put it into the right context.
Yeah. And if I may say, I may add, because we have the Kennedy protocol for children up to 17 years of age, and we always do virology, bacteriology from all organs, I still see COVID-19, and it's like having a cold. It is in the upper respiratory tract, and there is no histology that say, this patient had COVID. The patient had SARS-CoV-2, but it's a bystander. There is a question here from James that say, do you validate cadaver specimens for your assays if they are in-house? And how to handle IVDR assays that do not have validation for cadavers? I think this maybe is for Russell.
Yeah, I think we are trying to move away from the local in-house assay for various reasons, not necessarily because of IVDR. And we do have our local variations. For example, this tissue extraction is not a commercial one. So the bottom line is we're trying to get rid of it, but the extension of IVDR has given us some breathing space to look into the details of how the validation should be done. But of course, as you know, even outside the IVDR, there's a lot of validation, and the worry we've got always is, yes, you design the PCR and the extraction workflow, does it actually work? So that's the primary question we try to answer, and then the regulations come in.
Yes, and I know that we have run 4 minutes over time, but there were many questions. Many will be still unanswered. But the last question from Anonymous. I think it's for Rasa and perhaps also from Noha that is here because it's about the guidelines. Are the guidelines for lab diagnosis standardized? Where can we find those if this is the case?
I don't think that, and at least in the virology circle, there is no set guideline which we can point towards to say, look, this is what you need to do. But I think, Marta, what you have done in a way is a guideline, because all you need to do is, as the histopathologist doing autopsy, think of what are the best samples. Now, you can base it on autopsy based findings, or you can just have a standard protocol like you've got and just send samples from most of the compartments and then test and find out. So I don't know of any particular guideline.
Particular lab guideline.
The lab guidelines are just, I think, yes, we've got local guidelines which are more local. And they're not very difficult to come up with. So it's a matter of standardizing this across. Now, as Esther was saying, she struggles to find a laboratory where she can ask for some of the tests. So it's a matter of they can develop their own test. Glasgow is a big place, but they haven't done it. So, but it's easy to set up.
I have a question. Sorry, that I know we had two cases, Rasa. So you will like to answer. Raluca is asking, where you detect influenza virus closely after vaccination, do you distinguish whether this is vaccination strain?
Yeah, I mean, depends on which vaccine you're talking about. So the answer is, if you've got the intramuscular or subcutaneous vaccine, then you will not detect a virus in the respiratory tract because you're just given an antigen. But if you've given a live virus and you have taken a throat swab, as a live virus vaccine, which is typically used for the kids, the intranasal one, yes, you will detect it. And if you want to find out if it's a vaccine strain, yes, we've got tests available where you can differentiate.
And also remember, we recently had two cases that there were 2 deaths in the same school. The 2 children have had the vaccine the same day, the same influenza vaccine, but the viral load was very low. So you send me an email saying this is likely the vaccine strain. So thank you. It's always good, my advice. If you are a virologist, talk to your pathologist. If you are a pathologist, talk to your virologist, because then the feedback influence the results and the best results. So I think we have to leave it here. I would like to thank you, our esteemed speakers, for taking the time to present today. I'd like to thank you, Noha, for agreeing to organize these 2 webinars. This is the first. The second is going to be similar, but it's going to be on bacteriology with different speakers, also the lab side and the postmortem side, and it's on the 5th of March at 1 o'clock UK time. So this will be uploaded, the recording, and remember, spread the word about the 5th of March between the Royal College and ESGFOR groups. If you are an ESCMID member, join ESGFOR, please. And if you are a pathologist who are interested in postmortem microbiology, join ESGFOR as well. And thank you very much.